who in America is really concerned with Black women's ability to reproduce.
What is it about being a Black woman in the United States in particular that's not allowing us to have the same outcomes as women of other races?
My race, my gender, and how much I make directly affects the care that I receive.
It shouldn't take Serena Williams and Beyonce talking about their experiences for folks to wake up and see that this is a public health crisis.
In this country, we should be able to live and not die because you can't afford health care.
So some of the diseases that affect the Black community more than other communities are definitely hypertension, which is high blood pressure, diabetes as well, and then certain types of cancer as well. We're talking about things like cervical cancer and breast cancer. And even in situations where the rates might be similar, Black women are definitely affected more or dying more from some of these cancers.
My most recent healthcare struggle has been with my fibroids. I found out about 2 years ago now that I had one small fibroid. A fibroid is an involuntary growth in your uterus that is typically benign, but can be anywhere from a centimeter big to the size of a grapefruit, the latter at which point can cause severe period problems and infertility issues.
I've been living with lupus for the past 9 years. Lupus is an autoimmune disease in which the immune system attacks healthy tissue and it inflames it. So lupus is a Black woman's disease. Black women and Hispanic women are 3 times more likely to be diagnosed with lupus than our Caucasian counterparts. And our community needs to know about it because it's sort of a creeper, right? It presents as other diseases, it presents as other, really mild conditions potentially, and it can be deadly.
For a long time, there was like this idea that I would read about online or talk about with friends about doctors think that Black women can take more pain, or doctors don't take Black women's threshold of pain seriously. And I found that to be true with the first 2 doctors, the white woman and the white male. They were both at the hospital that I went to when I had to go to the emergency room. And I'm telling them I'm in a lot of pain and I've been bleeding for 20 days and there's cartoon blink, no, that's normal, that's fine. And this sentiment that something that's clearly not normal is fine.
It's so unfortunate that in the United States, we pride ourselves on being such an advanced nation, that Black women are still dying at 3 times the rate of white women in childbirth. And that crosses income, socioeconomic status, education status, age. It doesn't matter. It just means that Black women are dying in childbirth at alarming rates. And unfortunately, it shouldn't take Serena Williams and Beyonce talking about their experiences for folks to wake up and see that this is a public health crisis.
The healthcare system at large is ignoring Black women's needs. I think that that's been said a million times by a bunch of different people. There's even this viral video on Facebook of a man literally pleading to the government, do something. Black women are dying, do something. And the fact that these sad stories have to be taken to the face of our government in order for someone to give a damn, I think that highlights pretty well that we're somewhere at the bottom of the totem pole in regards to our health needs.
The issue is I think we don't fully understand, to be honest, what exactly is going on. Because when you do look at women of the same socioeconomic status, there's still a difference between, say, Black women and white women in these mortality rates. So the question then becomes, is it cultural? Is it genetic? Even when you look at women of African origin or along the diaspora in other countries, the rates are not as bad as they are in the United States. So what is it about being a Black woman in the United States in particular that's causing?
Good evening, everybody. Great to have you back here. It's Tuesday, July 14th. Thank you so much for bearing with us through some of these technical difficulties. We jumped different platforms tonight. And so for most of you who've been with us the last 5 or 6 weeks, we were using Zoom. and we upgraded. And so this fun platform, we are still trying to figure out. So I'm grateful to have my guests on tonight. Before I introduce my guests, I do want to pause parenthetically and share that tonight's discussion is really near and dear to my heart, not only because the Black community is really suffering from maternal mortality, but more importantly, this is a discussion that we don't get a chance to really talk enough about. And so, as I've been researching all week and talking to different nurses and doctors just across the country, I have been so shocked by how this epidemic is not anything that we readily discuss in the news. And so tonight we've got two star doctors who are going to talk to us more in depth about this particular issue related to maternal mortality. And the question, is America failing Black mothers? Before I introduce them, I do want to just kind of share a few thoughts about two celebrities. I have found that this maternal mortality affects the entire Black community, not just those who are poor and in the undeserved communities, but even those who are affluent. Recently, Serena Williams and Beyonce, who are at the top of their professions, Serena Williams, who's one of the best tennis players and arguably athletes of all time, and Beyonce, who's a singer who sells out arenas within hours. They both have experienced life-threatening complications in their pregnancies. Serena Williams experienced a pulmonary embolism a day after giving birth to her daughter by a C-section, and Beyonce revealed that she had experienced toxemia, a condition that left her body swollen, and she was confined to bed rest for more than a month before she had an emergency C-section. Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women. And according to a 2016 analysis, it is partly why the overall rate of pregnancy-related deaths has climbed over the past 2 decades, making the maternal mortality rate in the United States the worst in any industrialized country. Tonight we have Drs. Consuela Cruden and Dr. Clarice Otley. We do appreciate you both for joining us tonight. We do know that the hour is kind of late, so I do want to kind of jump in and just go ahead and get started with the questions. Dr. Otley, you have some great research, and I'll get into your research here in a minute. But your research really kind of stemmed around preterm deaths, and I kind of want you to talk about what maternal health is and what maternal death is. I think that those two definitions will really help set the stage tonight for most of the questions that I have. Dr. Ali, just turn your volume up. I think you're still maybe muted.
Can you hear me now?
I can.
Okay. I said, well, you've done your research very good. You were raised very well, obviously. And so I've done my research too. Both of those questions, not something that I think any of us can just rattle off the top of our heads. So in my research, in terms of what is maternal health is the health of women during pregnancy, childbirth, and the postpartum period. It encompasses the healthcare dimensions of family planning, preconception, prenatal and postnatal care in order to reduce maternal morbidity and mortality. As far as maternal death, according to the World Health Organization, is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration of the pregnancy from any causes related to or aggravated by things such as hypertension, diabetes, and any other conditions that might put her at risk.
Mm-hmm. Dr. Ali, really quickly, can you tell us what was your passion and excitement to go into the research area related to preterm death?
Well, I did have a preterm baby, and you're that preterm baby. But in addition to that, I worked on a maternity floor and worked in L&D and saw many women who came in preterm labor, labor that many times were arrested, but sometimes it didn't get arrested. And what the saddest part about it, I think, was when that preterm was so early that ended in a loss of that baby. And no one wants that to happen. And even though it didn't happen to me, just my own sensitivity in being pregnant and going through all that I went through to know that it wasn't going to have a good ending for some of these women. And what is it that we can do to help them was part of the passion for writing my dissertation.
I'm glad that we have both perspectives tonight. Dr. Otley, you have a PhD, and Dr. Cruden, you have an MD, so it's just going to be some very interesting conversation tonight. Dr. Cruden, I'm very interested in this really the statistic that I read earlier. According to the Centers for Disease Control, Black women are 3 times more likely to die before, during, or after having a baby. And more than half of these deaths, the Center for Disease Control says, are preventable. And so, what are the common causes to maternal death? And then part 2 of that question, Dr. Cruden, is can all of these be prevented, or are Black women predisposed to these causes?
You're right. That statistic, Jason, is stunning. And first, let me say thank you for having me on. I feel very honored to be doing this, especially with your mom, who's been a longtime colleague of mine. And I feel very honored and very grateful to be sharing this platform with her and to be doing this with you, because I think it's very important to really start to discuss these issues, because they're not easy situations, and I think it's going to take us many conversations and a lot of time to really re-understand what we haven't understood before in order to move forward in how to improve. And I don't like to say the failing system, because I think we have made a lot of progress, but to really understand how we move forward in continuing to improve our situations and recognizing some new challenges that really have come into play and have really made our work so much harder, because we have to change our course. We cannot continue to do and battle the battles that we have battled before in the same manner. So to come back to, after this long introduction, to come back to answering your question, some of the leading causes of death in pregnancy really extend from really the leading causes of death in America, not just in pregnant women, but in all individuals. And that remains heart disease and stroke. So the way that extends in pregnancy is pregnant patients automatically, because they are pregnant, because of the physiology of pregnancy, if they're already predisposed to heart disease and stroke, these risk factors will then translate in gestational hypertension, chronic hypertension, preeclampsia, pre-existing diabetes, pre-gestational diabetes, overt gestational diabetes with its complications of macrosomic babies, fetal death, preterm labor, and losses, but not just the losses, but morbidity in the offspring, in the outcomes, but also lasting morbidity. And I'm not necessarily talking physical morbidity, but lasting social morbidities in the families and communities of these pregnant women. How can we prevent those? And that's why we're starting those conversations. I mean, it is really not an easy fix. We have to understand what's at the root of those problems, and that itself is not easy. We can mention things like no access to care. We can mention racism, but then do we really know what racism is? Do we all understand what racism is and how racism affects things like access of care, education, job opportunities? I don't have the answers to that, but that's why we need to have those conversations like the ones you've started and the ones you're doing. But Yeah, we can definitely. I hate to think that we cannot do anything about it. We must,
Right.
and but how we gonna do it requires conversations, understanding, respect, and the willingness to see and to want to better ourselves.
Dr. Kuhn, I came across an article by Dr. Neil Shaw, Harvard Medical School obstetrician. The quote is, an American mom today is 50% more likely to die in childbirth than her own mother was. Um, that seems to be very alarming. And I'm just curious, what is happening today? Is it our diets? Is it women's lifestyles that has
Mhm.
maybe changed the trajectory of more black women or more women in general? It's not just black, but it's all women
Exactly.
are dying compared to their mothers.
Yeah, it's very it's almost like counterintuitive because one would think because our technology is now so much more advanced you know um, than decades ago, we should be doing better. We should have better technology. We can detect when care is needed quicker. But we're not a healthier society. We just have more information and more technology and more knowledge about how to live sicker. But we don't focus on health and well-being. And if I mean, and that's really, if you look at the way our health system is set up, it's not a system that is based on value, but fee for service. So we don't, as physicians, we don't get paid based on value, delivering value, but fee for service. But to answer your question, why do we have such worse outcomes? I think you hinted on it a little bit, and I'm not sure if it was Dr. Shaw, but somebody else talked about the cortisol effect. Cortisol is a hormone that is excreted during stress, and during appropriate stress, short periods of increased cortisol are very appropriate and can actually be life saving. When you're being chased by a lion, your heart rate goes up, your blood pressure goes up, you get that blood flow in your muscles moving, so you can run and save your life. So in those for those short-term increases in our cortisol levels, that can be life-saving. What happens in our everyday life nowadays is our cortisol levels are chronically elevated. We know that elevated cortisol levels are closely related to poor pregnancy outcomes because during pregnancy itself, you have higher levels of cortisol secretion. Now you increase those levels even higher with the already chronically elevated cortisol levels that those moms had pre-pregnancy, and that actually go even higher because in some of these situations, a pregnancy, not just physiologically to her body increases the cortisol, but now socially to her family. I mean, the financial stress that is added, the fact that now she has a complicated pregnancy and she can't go to work, she can't have an income, increases those cortisol levels even more. So even if you put this patient on bed rest and you do all the things that we have advanced ourselves on in obstetrics to improve our outcomes. We do the monitoring twice a week. We, do the ultrasounds. We do the any kind of monitoring on her. She still delivers at 24 weeks with poor outcomes. That's the cortisol effect. And we all, pregnant or not, if we measure our cortisol levels now, significantly higher than our grandparents because of the way we live our lives now and the stressors we are exposed to in our daily lives. And I
Can you
think that's how that
explain
contributes.
cortisol just for me and for others who may not be familiar with that term?
Cortisol is a hormone that is secreted by the adrenal glands, and it is really a protective hormone. It's like most hormones in our body, closely regulated based on what's going on and what's needed for survival in our body at any point in time. Now, any system in our body can overreact because we aggravate it, and we stress it out systemically and chronically. And that's what happens to our adrenals. Whenever we perceive stress, our body normally responds to stress, whether it's stress because somebody just jumps at you and you think you have to run, or whether it's stress because you think you're going to lose your job, and now you think you can't afford like the medications that your child needs. All of that is additive. Eventually, that excess cortisol has many different effects on patients who are not pregnant. You get excess weight gain. That cortisol can have effect on the reproductive system, where some patients who do want to get pregnant and are not able to get pregnant now have fertility problems. We see how cortisol levels can have effect on your cardiac health, your respiratory health, and also insulin and other metabolic illnesses.
Yeah, I appreciate you sharing that. That's so important. I'm learning a whole lot, even as you're discussing. Dr. Ali, I'm curious, your dissertation and research you alluded to earlier. I want to kind of dive into that a little bit. What other factors, and Dr. Cruton has mentioned some, I heard stress, I heard finances, and it's interesting, Dr. Ali, there are women I am finding are having less children now than years prior. I mean, your grandmother had, 12 or 13 children, right? And so I think gone are the days that women are having 12 and 13 and 14 children, but it seems to be an increase in the number of women who are dying due to pregnancy complications. So your research looking at preterm birth, preterm labor, the women you interviewed in your research, they didn't die, but what other reasons did you find that could be linked to pregnancy complications that could have a poor outcome?
One of the things that I thought was most revealing was the ideal of being a strong Black woman. And I've heard it all of my life. And the women that I interviewed, that was one of the common themes. And the thought is that being a strong Black woman is a great thing, but it has a stressor attached to it. And when you're pregnant and you're stressed already, then to try and mimic your mother or your grandmother or your aunt who can do exploits, and you feel like, well, I've got to be like them. And they're telling these daughters of theirs, you've got to be a strong Black woman. And so when the physician, the obstetrician tells you to go home and put your feet up because you are showing signs of preterm labor, and so that woman will say to herself, I can't go home and put my feet up. My mother will come over and say, what's the matter with you? Mm-hmm. Your dishes aren't done. Your house looks a wreck. I didn't raise you that way. You're a strong Black woman. You need to get up and do what you need to do. And so it became a bigger stressor for them to even try to live by the standards that their mother and their grandmother and their great grandmother actually had set for them. And the other piece of that, which I thought was very enlightening, is where did this whole thing of being a strong Black woman originate? I mean, who came up with that phrase? And it was sad to hear when I did actually do some reading and some research about it, that there was a doctor, Dr. Sims, out of New York in the 19th century, who was experimenting with slaves for a problem that they had, which was, it was a fistula. It was a hole between their bladder and their vagina. And a lot of the women, the white women, had these happen to them, especially after childbirth. And so he couldn't practice on the white women, so he practiced on the slaves. And they didn't do any crying, no anesthesia. He just practiced, and it, I understood it was a very painful procedure. And one woman was practiced on 30 times before he actually had a chance to take care of that fistula. So the Black woman, the African American or the African woman who was really like the backbone of the family before slavery. She was a strong woman. So we see the word strong black woman being threaded throughout, even in Africa before slavery, even during slavery, because even Dr. Sims said these must be some tough women. I'm doing all of this to them, and they're not even crying. Whereas when he tried on white women, they screamed and yelled because it hurt. So to live in a way where you have expectations on you and you're pregnant, it forces another type of stress that actually weathers the body. And that was the other piece of the dissertation. It revealed that these women suffered also from weathering. And basically, what weathering is your body's systems begin to age sooner than they should be aging. And the culprit behind it are stressors. And this particular case, it was being stressed because you were expected to be a strong black woman. So it didn't always, it was not always a good thing for them. It sounds great. I like the idea of being strong and black. I tried to mimic my mother-in-law, and I just was not an 8-cylinder woman. And I had to come to grips with the fact that maybe I'm only a 4-cylinder. Well, for these pregnant women, they didn't get a lot of options. And so it became not only stressful, but they had such an issue with it that they had to decide, do I go home and put my feet up, or do I take care of my toddler?
Yeah, Dr. I want to kind of get into that, the strong black women effect, right? I think I want to know more in your dissertation. Let's talk about your recommendation section, right? Towards the end of all of the research, when you collected the data, when you reported out on the data, and you got to the recommendation section, and you talked about this strong woman effect. What is the alternative? Because if these strong black women are going home to take care of the family, if in some cases they're single parent mothers, in some cases like my grandmother who worked 2 and 3 jobs, what is the alternative?
Well, I think one of the things that came out was the reality for these women was that they did not have to, quote unquote, be a strong black woman, and that they could actually educate their mothers and their grandmothers to the detriment of even being classified as a strong black woman. The women should not be put in a position where they had to choose between the pregnancy that they currently had and the 2 toddlers that were running around the house. And so one of my persons said, I had to choose between which one I was going to be able to help. And she said, and I chose my toddler, which meant if she went into labor because she was in preterm labor and the outcome wasn't good, it was not what she wanted, but she had to choose. And I think these women in the recommendation section, it says they needed to understand that they no longer had to live that quote unquote ideal of being a strong black woman, that they could in fact go home and yes, their kitchen may be full, dishes may be in the sink, the laundry may not be done, and mama and grandmama might come over and chide her, and she could say, you know what, if I did those things, I could lose this pregnancy. And the mothers would probably say, well, I did them, but they had to speak out. They had to learn to speak out about this particular ideal. The other thing that I thought was very interesting too, that came out of it as a theme, was the whole issue of weathering. And weathering is chronic if you experience something all the time. Any of us can be stressed for something for a small amount of time. But if it's something that's 24 hours a day, 7 days a week, 365 days in a year, that because you're black, you are stressed. And it manifests itself in many kinds of ways. And the research actually reports that those stressors are passed on through something called intergenerational epigenetics. And that's a whole nother conversation because it's not a very easy concept to explain. But basically, it's been passed on through generations. So when you think about 400 years of slavery, and you think, well, here we are in 2020, certainly you as a pregnant woman are affected by that. But the answer is that's not necessarily true. She is affected by it, and she doesn't even realize that she's affected by it because of this epigenetics. And then you add on weathering, she is now even at a worse disposition because she's aging internally from the stressor that she can't get away from. There's nothing wrong with being born black. God made us that way. But there are things in our culture and things that we experience as black people that will not let us even have a moment peace of getting away from the reality of what detriment racism does.
Dr. Cruton, do you find the women who come into your hospital and are preparing to give birth, are you finding that you having to tell them to get off their feet, to take time off work, to change nutrition? And then are you also finding that those recommendations that you're providing, that they're not listening to?
It really depends on the situation and the diagnosis. I hardly ever tell my patients to get off their feet. I like for my patients to stay active. But, we're talking about cultural differences too. Even within the Black communities, there are several cultural differences. Um, so yes, I think what Dr. Otley has described, I have definitely seen in certain segments of our population, but um, there are, I think, you know, what Dr. Otley mentioned was more like the expectations from their community, in their familiar, like their family community, which we see less and less now. I think it is more of a peer pressure community in the generation of pregnant patients that we're dealing with right now. For example, my neighbor, my friend, less so of that, my mom, my grandmother, this is expected, this is what our family does. Unfortunately, I mean, there's good and bad about that situation, right? Because I think the other thing that I forgot to mention as the cause of why we are so much worse off in our in our pregnancy outcomes right now than 50 years ago is the fact that we have lost sense of community. We have lost sense of taking care of the person. We're more taking care of the technology of the pregnancy, but not the woman who is pregnant. So I think that loss of community has brought us to this point of where we are, struggling different battles. But yes, definitely, I see more of a peer pressure expectation of society rather than a pressure of culture and family,
Mm.
fortunately and unfortunately.
Mm-hmm, mm-hmm, mm-hmm. And so we kind of started the conversation around what can we do to decrease the number of women altogether who are dying, because this country boasts the largest number of women who are dying because of pregnancy complications. That's kind of how we started this conversation.
Mm-hmm.
And I want to make sure that we tie the thread in your research, Dr. Ali, and then what you do on a daily basis, Dr. Cruton. What type of things can we begin recommending, right?
Mm-hmm.
I don't want to leave the call, and then I don't want to share this message, out into the World Wide Web, and then we not talk about some of the things that maybe we weren't doing 20 years ago, 30 years ago, 40 years ago. So if the two of you could kind of talk about how we have progressed in the last 20 years, maybe where we are now, and what we need to do really moving forward to see the numbers come down.
Mm-hmm.
The research that I saw indicated that 60% of the deaths could have been avoided, and I was not aware of that. So when you look at the fact that we're saying, yes, Black women are dying at 3 to 4 times higher rates maybe than the white woman, but that 60% of all maternal deaths, especially regarding the black woman, is preventable. And so I asked myself the question, well, preventable how? What else could we do? And what came to my mind as I remember teaching nursing students and the textbooks that were used, there was very little information about pregnancy, preterm birth of Black women, maybe a paragraph, maybe two paragraphs. So I think that because it is a well known fact that Black women suffer higher than any other race, why isn't there more conversation? Why aren't more textbooks addressing it? Why don't we hear about it in the hospitals? And I'm sure some do. They, they are high risk patients just because of the fact that they're Black. And everyone may not see that as being the case. They may not see a Black woman who seems to be fine as physiologically. The pregnancy seems to be fine, but maybe being Black could be one of those risk factors that would make her a high risker. And I think that if we could do something even with that, that would, I believe, lessen some of our numbers. So my thoughts are that people like myself who love research and like to maybe write, that I could contact some of these um, books authors and say, let me put a chapter in. Let me put a chapter in about pregnancy and culture and Asian women, Hispanic women, African American women, uh, Native American women. They are all experiencing deaths, and I think once students understand that as nursing students, and they take that into the hospital, and physicians understand it, and mothers understand it. I think the lack of understanding the magnitude of this needs to be exposed in other areas than what is being exposed in.
I think as a physician, I look at it in several stages, right? So for our pregnant women, how can we improve? And especially for our minority pregnant women, how can we improve our outcomes? So I'm thinking in lines of timing. We're gonna have to like kind of sort of disperse our efforts based on timing. We have to work timing and location. So from a timing point of view, I'm thinking, before she even gets pregnant, how can we improve her overall health? So before the pregnancy, during the pregnancy, how can we improve access to care? Because oftentimes the a lot of those minority women come to care very late. So how can we improve that access? But access is not just access to healthcare, like true access, because if this patient goes to the emergency room, they have access too, but that's not proper care. How can we bring that care and that education and that the importance of access or receiving healthcare? How can we get it in the community and get them to understand the importance of that? And as far as location, so we have our job as physicians to do before the patient gets to the hospital, and then as the patient gets to the hospital, what is our role? What is our job? And I'm talking more about the sensitivity part. As physicians, we're trained to profile patients, no matter who you are. You're a white person, you're an Indian person, you're an African American person. Because you're Black, we're going to screen you for sickle cell. Because there's such a minority of African American patients that have sickle cell and that are affected by sickle cell disease, but still we're using, that 39-year-old African American female. Why? For what reason? The 25-year-old white female. Why? So we're going to have to become sensitive to why are we using those expressions? What is our true role? What is our true purpose? And I see this as a tremendous opportunity in medicine to to do a better job in really recognizing when our biases can lead us astray. So we are very good at, you know, taking care and taking care of people and do what's safe. We're very good at that. I mean, when all of this started, I started thinking, and do I have biases when I take care of patients? No, it doesn't matter who the patient is. I always make sure that, I take care of the patient. I will do anything. I will cure, I will save. But do we give care that is supportive? I think that's where we can grow. Is our care always supportive? I think Dr. Otley mentioned, the I can't remember now. You mentioned something that made me think of this. But are we supportive to what the woman thinks and what she feels? A good example of this is when we assess for fetal reassurance. You know, we put the mom on a monitor and we assess the fetal heart rate. This is technology. But even if the mom complains of decreased fetal movement, we kind of sort of disregard that because our technology tells us your baby is fine. Go home. Your baby is fine. So giving more support to the mom who tells you, my baby is not moving, I'm concerned, I'm worried, I think my baby's going to die. Giving more support to that, I think, is what we need to focus on in healthcare.
Yeah, I want to just ask a couple of questions from our chat box, but your last point, Dr. Cruton, was an article I read earlier this week related to culture, and it was saying that Black women who talk about complications in the hospital related to pregnancy are often told to go home, and often told that everything will be okay. And so some of the narratives is they're not being listened to. And so I think that might be some of the biases that we do, that Black women
Absolutely.
are experiencing in the hospital. And if we have enough time, I do have a question related to bias, but I do want to jump into some of the questions in the chat. There's a question I ask you, Dr. Otley. How important is preparing yourself health-wise prior to pregnancy?
Well, one of the things that I found is that a lot of Black women don't even realize that they're pregnant. It's not like they planned it. They just, one day they said, oh my goodness, I can tell something's going on with my body. And then they do some tests and they're pregnant. So they didn't have any preparation time. But the best thing for any woman who wants to have a baby is to begin her body in preparation to, do her exercises, eat properly, drink the appropriate amount of water, to get ready for 9 months of caring for a baby in the best way she can. And because I think many women may not even realize that they're pregnant, a few, and I don't know what the number is, they're planned pregnancies. But we're talking about the majority of the unplanned pregnancy. So if it's unplanned, that she may not be physiologically ready to the best of her ability to be able to even do that. She manages it, but could she not do a better job if she had had an opportunity to do some more planning prior to becoming pregnant?
Mm-hmm. There's a couple of comments here, Dr. Otley, that are asking that you write your book. I think you made some recommendations of what needs to be done, and a few comments here saying you need to just start writing a book. So I just wanted that I shared that with you. One more question related to that, though, Dr. Otley, women who need to prepare themselves for pregnancy, even as they don't know that they may be pregnant, nutrition, exercise. There's a comment here about women who go to the hospital and refuse to listen to elders, the mom, grandmom, because of what the doctor has told them to do, right? You and Dr. Cruton both talked about that earlier. The village, who has the influence? I think Dr. Cruton mentioned that it's moving away more from cultural to peer influence. And if you look at education, the same thing happens with students. And parental influences usually leave at the age of 10 and 11, and then come 12 and 13, it's peer influence, right? So what advice would you share with women who grandmothers, mothers, and elderly family members, they're refusing to hear messages from them. Are those messages so antiquated that they need to listen to the doctor, or is it a balance of both?
Well, I think that because physicians have spent many years doing what they do, and grandmothers and mothers have their opinion of how things ought to be done. I believe that the difficulty is in finding the balance between the two. And for women who uh, want to be pregnant and women who have their babies, you got to make a decision. I remember having you, and one of the things that my grandmother said to me was, you need to make sure that that baby sleeps on his stomach. Well, research supports that that is the worst thing that can happen to a baby is having that baby sleep on its stomach. Did the doctors tell me something different? Well, they did, but who did I listen to? So there's a lot of power that comes from a grandmother and a mother that would make a person who has a lot of knowledge even question which one should I do. And so at the time, I was not a nurse, and I do remember strapping you into the crib and not letting you turn over on your back. And I just thank God that He allowed you to live. Um, but we can educate our mothers. We can educate our grandmothers. They no longer need to live under an assumption that this particular thing or way I think is the right way. And it can be done in a very respectful manner. But we do honor those physicians who've spent many, many years, as well as evidence based practice and research that says this is what's best. I know your mother may not think so, but this is what's best. And so it can become somewhat of a challenge, especially when you don't do what your mother or your grandmother tell you to do. But I believe those conversations around the table where you share, this is some insight that I've had, and I do prefer to go this route. As much as I respect what you're telling me, I'm going to do something a little bit different. And it may or may not be received very well, but we have to take responsibility of our own lives. We cannot allow even our family members or anyone else, friend, a girlfriend, to tell us what to do. But I believe what would be very helpful is for those that are in the know, the village mentality piece of it. If I've learned some information as I did through my research that I can share with my girlfriends that say, this whole strong woman mentality stuff, this really is a stressor for you. You don't have to do that anymore, even though your mother may expect it. And so then because they listen to me. We're friends, and I help, and then they help because the message gets passed on. So I think that's how we change a culture. You don't need 100% of the people to change a culture. Joe Tai, who is an author, says you only need 30%. So you take 30% of any group of people and put them around other people, and that 30% can change a culture. And that's what we're really looking at. It may be in high school or in I guess they call it eighth grade or fifth grade, that we can begin to introduce to those young girls and young boys, because they need to know the detriment that happens when you have pregnancy complications. Why do we wait until a woman is in her 20s or 30s and start to talk to them about pregnancy complications? Why can't it be when they're young girls and young boys? Why can't it be when they're teenagers? Why can't it be when they're young adults? And I think that kind of thing needs to start. And I can be a part of that. We all can be a part of that to make it change.
Yeah, speaking about detriments, Dr. Cruden, is a lack of prenatal care or seeking care too late a detriment to a woman's pregnancy?
It can be, especially, we talked about, the leading causes of that being heart disease and stroke. So especially if you come into the pregnancy with risk factors. So do we have patients go through pregnancy with one or two visits and they're fine? Yeah, of course. But we're looking at, on a population basis trying to improve outcomes. So problems in pregnancy stem from problems before pregnancy. So, and I'm not necessarily referring to the physical problems of hypertension, obesity, diabetes, but also, what I had touched on earlier with that cortisol effect. A lot of the other stressors in a young woman's life, and especially in minority groups that are probably even more taxed with those stressors, those emotional problems that are not that visible, but probably have a greater impact on her pregnancy outcomes than the other physical ones. Because if she has a high blood pressure, she'll get a headache, she'll start to see stars, and she'll at least go to the ER. But the other stressors that she's learned to live with that blindly have impact on her pregnancy that she's not aware of, she'll come to the hospital and she'll deliver a premature baby that may not make it, or a premature baby with a great extent of morbidity for the rest of its life, and for her community to help her and to aid her with, or not, and then it does a lot of harm to her socially and financially. So yeah, it's not an easy fix, but I think we have a tremendous opportunity as physicians and people working in healthcare. It's really a fine line between clinical intuition and effective racism that we really gonna have to realize, because when we profile patients, which way, right? History of, or, um, Black, Asian, whatever. We already, I mean, I can be on the phone and I have a picture
Yes.
of what to worry about and what risk factors to worry. Immediately, it just comes so natural. So being able to really decipher and really to become aware of it is going to be very it's really what we have to do, and it's not easy. But becoming aware of, okay, am I doing this clinically, or do I prejudge? I'm going to order this test because I know, because of that, and we have done this. We have done this systematically in healthcare, in medicine, and I think this is really a good opportunity to become aware of it,
Yeah.
and to see how we can improve by becoming more aware and becoming more supportive, not just safe, because we know how to do safe care. We know how to save people's lives. We know how to improve immediate morbidity. But we're not that good at being supportive and culturally sensitive. So I think overall, I would say, I don't know how much time we have left, but, I wanted to kind of sort of close with my final, what do I recommend? So if this is not the final yet, I'll wait.
Yeah, hold on, because I want to just get to one more question. They've been coming in the chat very quickly. This theme here, though, that I want to touch on. You mentioned it earlier about bias, Dr. Cruton, and then now you and Dr. Ali have mentioned the word awareness, being consciously aware, which I believe is vitally important. In the chat, Gene Mickens mentions unconscious bias can affect doctors' approach. Pernetta mentions, I think everyone may have some level of bias, therefore it is important to have self-awareness. And Kathleen says, as healthcare providers, we need to do a better job of teaching our pregnant patients how to manage conflicts between what we're telling them and what mother and the grandmothers are telling them as well. There just seems to be this theme of being consciously aware. And so this question that I have for you, Dr. Cruton and Dr. Otley, and then we'll have you all both do final thoughts. As biases occur, because I'm not going to ask the question, do biases occur? They're unconscious biases. So as unconscious biases occur in hospital settings, specifically for the underserved communities, low socioeconomic communities, low income, and now we're talking about Black mothers to be, do either of you, in your opinions, believe that this unconscious bias could be a contributor to maternal deaths in the U.S.?
I believe that it can, um, because if I go to a physician, for instance, if I'm pregnant and I go to a physician and he or she may spend 3 minutes, 5 minutes, whatever it is, just talking to me about my pregnancy, and they may spend 30 minutes with someone else. I call it Jiffy Lube. Something down on the inside of me says, well, why am I not getting the same amount of attention? And I think that unfortunately what women do is they may go to an obstetrician because they've been recommended or they don't know. And if they don't feel that that physician is giving them the time and the attention and listening to their questions and taking time to address them, I think that should be a red flag. There's nothing that says that you have to continue for the rest of your 9 months or 8 months or whatever it is with that physician. If you don't feel that he or she is giving you what you need, and you don't know whether there is a bias because that person may not even be aware of it themselves. But I believe it's true. Just like some physicians have problems with women that are fat, they treat them differently. I've seen it happen, and I've heard them talk about it. And some who feel that way may not say anything about it. So I do believe it does occur, but I believe there is a responsibility also on the woman. There is enough research that they can go online. People are online for everything. They Facebook, they WhatsApp, a lot tweet, they trip. I don't know. I don't even know all the terminologies. I just know that just about whatever you want to find out, you can find it out. And if you put in a search engine, black physician, for instance, if you want a black physician, then put a search in and see who might be in the area. And if they're not in the area, is it important enough for you to go out of the area to do that? Some women don't want male doctors, and yet they may go to, say, a clinic, and that's who they'll find in addition to maybe a female, but they don't want a male doctor. And if they're going to be, and they may have their own biases. Pregnant women have biases, physicians have biases, we all do. And so I think it's incumbent upon us as women, especially those that are pregnant, to find the right fit. And I think they'll know it. I think you can tell when someone really cares about you and wants the best for you versus someone who is ready for you to get your 15 minutes and be done so I can bring in the next patient.
That's good. Dr. Cruden, same question. Your thoughts on how unconscious bias related to women of color may lead to early deaths?
Definitely. I think, we all have biases. Physicians, definitely, that's how we're trained. We're trained to be biased because if you're biased, you can develop your clinical intuition. You have to do that. I think, like I stated earlier, the art is recognizing when your bias is no longer for clinical intuition and saving and curing and protecting the patient, but other conscious or unconscious reasons for being biased. But I also think that it goes back to the patients too. And I'm hoping that we can all resolve our biases in a healthy way where minority or black women or women in general will not feel like I only want to see a black woman, or I only want to see a woman, or I can understand the woman part because women feel more comfortable with women, but that it becomes less of oh, I only want to see a black woman. I don't want to see that Asian woman. So we're also patients. If we create an environment where patients feel safe and they feel that no matter what color you are as a doctor or sex, I feel safe in that environment and I feel that you hear me. I feel that you trust me. I feel that you are supportive, and I want to come and receive my care from you. So I hope it kind of works both ways. And but I think we have the opportunity and we have the responsibility as physicians and healthcare providers to 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 create that environment. But it does go both ways. And yes, biases, unconscious or conscious, do affect outcomes in health. Absolutely.
Okay, good. Dr. Coon, it's been a pleasure just to have you and Dr. Ali on tonight. If you could just share some of your final thoughts, then Dr. Ali, you share some final thoughts. I just want to give everybody some instructions for Thursday because we're going to come back on Thursday and have a very, very similar discussion. There's no way that we could talk for 1 hour about such issues like this. And I want to make sure that we do spend enough time on Thursday to continue this conversation. So, again, Dr. Cruton, it was a pleasure having you. If you wouldn't mind just
Thank
sharing your
you. Sure, and I think most of this I've already said, but just to sum it up, I think it's for us, for all of us, in this community, it's our I see it as my opportunity to teach my patients how to deal with stressors and anxiety, other than giving them the medication and treating their high blood pressure, treating their diabetes, but also focus on a majority of our patients are well or healthy, but it's primarily that cortisol effect that affects their pregnancy outcomes or their other pre-pregnancy or post-pregnancy health status. So mindful breathing, things like meditation to decrease their cortisol levels, overall improving their health and their well-being. Create communities where people, especially young adults, teenagers, create real life social networks. And I'm not talking about this kind of social network, which is great, but I mean, creating real life social networks where communities come together, sit at the kitchen table, organize groups, go out there and do the work, do the outreach activities in their own communities so they can realize what their social stresses are and what they have in common, and in that way improve their overall health status. And then for our healthcare community, again, treating our patients in a culturally competent manner, to overall decrease their stress, make them feel more comfortable to receive their care from us so we can optimize their care, recognizing racial bias in order to improve our patients' health outcomes.
appreciate you, Dr. Cruton. Dr. Ali, any final thoughts?
Yeah, I think the other thing that's needed is, and I think Dr. Cruden even touched on it, is the whole idea of cultural competence. Uh, we need healthcare workers, nurses, we need patient care techs, we need everyone to understand that we're dealing with individuals who have cultures that are different maybe than mine. And instead of me imposing my culture, even though I may think and know that something may be best for that patient, there's a way to go about it. There has to be still respect for the patient you're dealing with. So if you have an Asian patient, for instance, and she has the issue of hot and cold, or you have a Native American or Hispanic patient who doesn't take a bath for 2 days, instead of uh, coming up with your own ideas that she's lazy and she's stinky and she's not even taking a bath, maybe stop to consider that that's not her culture that lets her get up and take a bath after she's had a baby. We impose, I think, our beliefs. We impose even the things that we know to be true, that we've learned, and we feel that it can be generalized across the board, but it really is not the case, whether it's a Black woman or Asian woman. But we need to be sensitive, and the only way we can be sensitive is to understand what their culture says. And I think for the African American woman in particular, as I am one, it would have been helpful for me through all of 4 of my pregnancies if I had the nurse who focused on me, the person, and not that she's got to get this done by this shift and this is the way that we do it. So I think that a community uh, needs to get involved, not just a few girlfriends, but to get a whole community. And that's why you talk about a village. So there are certain women that other women will listen to, and they won't listen to anyone else. If you happen to be that woman, find your platform and you begin to teach and help people understand, help Black women understand things that they may be up against. And if it can help them, if it's a grandmother, then maybe the granddaughter will be the one who will benefit if the daughter didn't get a chance to. But we've got to continue to make efforts to change the statistics and the outcomes. We've been doing this too many years. And have we improved that much? And it seems as if we haven't. And I believe it needs more conversation, it needs more visibility.
Yeah, more conversation, more visibility, all of which will take place on Thursday. And as we continue this series that we have been doing the last 5 weeks now, it has just been an amazing series on uplifting our community, empowering our communities from within, bringing in phenomenal speakers from across the country. And to get the advice that Dr. Cruton and Dr. Otley shared tonight, you either have to go in and pay a copay, and if you don't have insurance, you'd have to pay out of pocket, or you have to enroll in a class. And so we just appreciate just all of the thoughts that came tonight, all of the expertise, your background, your experience, Dr. Cruton, Dr. Otley, thank you. On Thursday, everybody, if you're still listening, we're going to talk about the top 3 leading causes of death for women of color, the top 3 leading causes of death for women of color, and how we can, as a community, not only be informed, but as we can begin to develop some new uh, new lifestyles that will allow us not just to just live longer, but lifestyles that would give us opportunities to provide a wealth of information for each one. And so, as I've mentioned in the text tonight, if you're following, I said to you, each one teach one on Thursday. Bring a guest with you. Let's continue to empower our phenomenal village. Super excited about what's to come. Dr. Ali, Dr. Cruton, thank you again. You all have a blessed
Thank
evening.
you.
Everybody, we'll see you on Thursday.
Okay, thank you,
Thank
Jason.
you.